Hello, welcome back. And we have a couple of other panelists that'll be joining us in a moment, but I'll go ahead and get started. So welcome back to the panel here on a roadmap for digital mental health integration into healthcare. So this is part of a work group that was put together earlier or late last year in the society. And what we saw was that there's a lot of implementation going on in healthcare systems around the United States. And most of these are done as business arrangements between a company and a healthcare system. So the goals are usually do not include dissemination of the processes and the results. And so there's a lot of learning going on, but there's no way to disseminate that. And so we put together a work group that included representatives from 7 healthcare systems that are implementing digital mental health, 10 companies that are implementing digital mental health. We interviewed, more than 20 people, and the work group has been meeting now to go over those materials for a number of months. And so the goal is here to surface that information and to put together a playbook that will be coming out later this summer. So we're going to talk today about just a few of the themes that have been emerging. And we'll leave about 10 minutes at the end of the session for your questions, and just put the questions into the Q&A and we'll get to as many of them as we can. So now I'd like to move to introducing our panel. We have Trina Histon, who is the leader of the work group, and she is also a VP for clinical product and strategy at Woebot. And before that, she worked for more than 20 years at Kaiser Permanente, where, among other things, she oversaw the development of Kamai, a digital mental health platform for connecting Kaiser members and digital mental health companies. We also have Youn, who currently is with Reliant Medical Group and OptumCare, and is also on the faculty at Harvard Medical School. And she was also a member of the work group. And then finally, Faye Sahai, who is a founding and managing partner with Telosity Ventures. But before that, she's had many, many roles. She worked with Kaiser Permanente for many years, and ending as VP and Executive Director for Innovations and Technology. And before that, she was with Blue Shield of California, Senior Director of Healthcare Services. So welcome, all of you. I am really excited to get started here. So why don't we just start with, let's assume that a healthcare system has made a decision that it wants to explore a digital mental health service. How do companies and healthcare systems first connect and engage, and what's the process?
All right, Sue, since you're with the health system, do you want to take that first? And then I'm happy to speak to it from an industry perspective. And then Faye, I know you'll have perspective too.
Sure. So I think the very first step would be just for the business strategy partnership managing people within the healthcare system to start making connections with different digital intervention companies. I know we're going to talk about like how to do the evaluation and stuff like that in a second. So, but within the healthcare system, there's people that are tasked with developing these partnerships, understanding what's available in the landscape, and really fostering that relationship so that everyone is having an open communication back and forth, understanding what are the needs within the healthcare system, as well as like what are the products and content that we can expect from the vendor partner.
Yeah, I think that sounds good. And I think in my experience, there are probably many doors in to a health system. You may meet folks at healthcare conferences and have a discussion and really understand sort of some of the pain points a payer or provider or a health system is dealing with. And then you can kind of think about how you might begin to meet those pain points in partnership. But I think to ready yourself for sort of a long series of conversations, because as Sue said, there's the business folks, there's the clinical folks, IT folks, policy, And so you really will be learning the sort of whole view as you evolve these conversations. But there might be an innovation door, for example, in a healthcare system that you can start with. And or it's a big kind of moonshot a company wants to make, for example, on mental health, that you could also plug into. So I would say many doors, and open all of them.
I agree with Trina. Many doors from that standpoint, and not only with conferences, it could be, you could see like the top department head in that area if you're working in that particular area of kind of the mental health and the behavioral health, approaching them. They might be speaking at a conference, as Trina was saying, to approaching them. We've also seen that upcoming of innovation challenges where companies are really looking and submitting yourself into challenges and getting recognized. Or as our kind of amazing panelists here, they also sit and judge many kind of challenges from that, or are always kind of scouting from that. So there's always opportunities to get your seen and heard. But I would say it is a longer sales cycle from that. We're seeing it 12 to 18 months in some cases, kind of on average, unless you have a really strong relationship already with that, heavy traction, clinical evidence, and a little bit more mature from that standpoint. So.
Can you say a little more about that, Faye? The 12 to 18 months, because I think that's something that often surprises companies initially. What accounts for that long sales cycle?
Yeah, I think kind of goes to Trina's point, is there's many people involved. So say you go in the door and you're actually working with a clinician and provider, and they're really interested in piloting your solution. They'll have to get that solution approved. And that part of that approval process is the procurement process, right? The business, contractual, intellectual property, your financial standings, where you're going. Then you have the technical component, right? So how secure are you? Where's your data handling? How's your privacy? Where's the backup going from that? Then there's kind of a process operations. So what's going to happen to pilot your solution in that area? How is it going to impact quality, operations, workflow, where it's going from that? So there's several components that kind of are involved in that.
All right, and then what are some of the ways in which we're seeing healthcare systems evaluate digital mental health companies? What are the kind of the key components that they're looking for?
Again, Sue, do you want to start there? And I'm happy to speak
sure,
from the other side.
I think the thing that has changed and has become more of a standard, I think, ask these days is having evidence to support the product or content or program that the vendors are bringing in. I think our team does it, what takes it one more step forward. We have a dual evaluation process. We have a data process evaluating the vendors, as well as a clinical process. Where we have a dedicated clinical team who's also doing demoing and testing out of the product itself to make sure that the components of the program itself have what we believe are clinical key indicators or mechanisms of change that we would expect to see to match whatever change the vendor is saying they're hoping to address. So for example, if a vendor is saying our program addresses anxiety, great, by doing XYZ, then our clinical team would go in, demo it, and then really test out, okay, we're seeing A, B, C, or XYZ in order to really address anxiety specifically. And if there are other things that the program would also help, is something that we highlight. But we want to make sure that we are able to convey then to our providers and the other people that we work with, that someone and a dedicated group of clinicians who understands what the patients are needing, what the providers are going to be asking about, have actually tested out the product so that they don't have to do that themselves later on. The data team, we have a dedicated in-house data team that also does a similar process on the data side. Because a lot of the products that we'll be bringing will not be part of a trial per se. There's other types of ways to have this kind of partnership, but then with the way that we do it, we're bringing it and really give it to our patients as part of care. So we feel strongly that we shouldn't be giving something that is currently being very early on tested. but something that has evidence to support that patients or users really like it and that they will stick with it. They don't just like download it and look at it for 2 seconds and then stop using it, but something that shows like some sort of engagement. I know this question came up earlier during the keynote, like what is engagement? How should we measure? We can absolutely have, I'm sure, a very debated conversation about that, but some metric of engagement that shows that the end users really will use the product to the point of actually showing some sort of benefit. And of course, that there is benefit that is being felt by the patient in this case. So those are the two key metrics that we use on our end.
Yeah, and I think I'll just kind of underline all of that, everything Sue said. If you were recording that and could play that back, I think that would be a great beginning of a blueprint for those of us in industry. You know, in my experience, I think absolutely, and I kind of think the methodology of human-centered design, where you're really bringing people, the end users, like patients, clients, however you want to frame the end users there, and the clinicians, because they absolutely, in augmenting a plan of care, want to make sure that the tool is doing what it says it's going to do, that it is going to help somebody, because the last thing you want to do is give somebody something that may not work and that isn't very reinforcing for their patient. So, you know, in my experience, the clinicians you can bring along the journey and really lean into their expertise and say, well, how would you refer this tool to a patient? Like, we think about the tool being the be all and end all, but really it's half the story. The other half the story is how and where you're deploying. And the context is just super important, because you can have the best tool that never gets referred. So really leaning into understanding, how might this be put in a patient's hands? How do you make that as easy as possible from an EMR integration clinical workflow? And then, you know, me as a sort of an end user, what I'm going to value may be quite different to what the clinician will value. Like, we both want to see improvement, that I'm feeling better, but how that feels for me might feel very different. It might be a PHQ-9 score for the clinician, whereas for me it might mean I'm going to my book group, or I'm out and about and I'm being with my friends again. So all of that matters over time, that you're sort of have an evidence generation strategy in a portfolio, but also for companies that have sort of that innovation arm, they are sort of willing to partner, even if you're earlier in your journey and you don't quite have you know, all of the science built out, but the solution is so novel that they are willing, again, as Sue said, to test with clinicians and sort of see how that feels. So there's some early steps.
And I would just also just add, and totally agree with all that was said too, is that I think it's really important to get your expectations aligned all the way from the very beginning. So, so what does the provider kind of expect? The ease of workflow, not taking too much time, having a positive impact on their patient, right? And versus our patient, right? Being able to, that it's something custom for them, that it's going to be easy to use. But I would also kind of, in a sense, look at, how are you going to measure that? And then what is your expectation? What does the success look like? Because I think in some senses, if you kind of look at, you know, the different perspectives, a startup's kind of looking for number of companies they're working at. So they check the box and they're working with you. That's great. But now the next box is a number of users working on that. And if success for you is number of users and the providers is clinical impact, are you measuring that? Right. So you're just making sure you're in alignment with that, especially when you're starting the pilot and you're starting to build that relationship and trust is so critical.
So we're already kind of shifting into sort of, it sounds like implementation planning and defining metrics and so on. So why don't I just use that as a segue here? So what are the things that need to occur during the implementation planning phase? So when we're talking about a pilot, maybe given that you know, means something, may mean something slightly different. Maybe you can just define what a pilot is in this context.
Yeah, I think I want to highlight first what Faye said, because I can't stress that enough, and I also I think adds to the timeline of 12 to 18 months on average, right? In terms of how to think about this kind of partnerships, and whether that leads to a pilot or a more extended kind of phase out or rollout. But I think aligning at the very beginning of the conversations with all of the relevant parties vertically within the healthcare system not just the leadership who's going to have to give the green light at some point, but that is just not green lighting the pilot, but also green lighting, for example, okay, if we meet all of these, smaller scale metrics at this like smaller number of sites or patient groups or whatever defines that pilot phase, then also aligning with like, okay, what is the time frame that we're expecting for ourselves? Like what is going to be then evaluated in order to move on to a larger rollout or implementation phase, as well as like going vertically down, like how do we integrate and communicate who are the right technical, leads as well as analysts in order to really partner with, or the clinicians that we should be discussing to potentially even learn from, ideally, from an even pre-pilot phase, if that's available, to think about within that healthcare system, like other characteristics unique to the context, the setting, the providers, the patient groups, or how are you thinking about bringing our company into that healthcare setting that might be unique or similar across sites or across settings within even one healthcare setup. So I think the more visibility that can be shared and asked about, I think early on, the less bumps in the partnership along the way. And I think it's just something that, everyone lives in their world, everyone makes assumptions. And I think just making sure that that conversation is happening early on. So as much alignment and transparency can be available on both ends would be great. So just wanted to kind of highlight that first.
I think everything you said, Sue, everything you said, Faye, and so from the industry side, sort of I think of sort of breaking that down, because it can often feel like you never get out of pilot. I'll just kind of say it that way. But pilot really is iterative, and I would say if there's one word to describe everything about implementation, it is dynamic. So you do remain very adaptable, but kind of think of it as either a crawl, walk, run, or a phase 1, 2, 3. And so what would you do if you're crawling? And things to consider are, is this the first digital mental health tool your partner is deploying, or are you part of an ecosystem, or they've been doing it forever? Because that would be a very different starting point depending on the answer to that question. I think looking for what I will call innovation-minded clinicians, like, so they really are excited to try something new. They recognize that and are welcoming more tools in the clinical toolbox that they can support their patients with, because they will be sort of your earliest advocates, but also bring their peers along. And as Sue said, deeply understanding the context in which they're delivering care. So I think about primary care, for example, and digital mental health. On average, a primary care clinician is 17 minutes. They're covering 6 to 7 topics in that time frame. And then you want them to think about your solution. So it's kind of hard to juggle all of that. They're holding a lot, and they're holding space, obviously, for the patient and what they're there for, the reason for visit, and how they're going to support a plan of care and building that out. So in a crawl phase, you might start with like 10 clinicians, and you might look at the first 25, 30 referrals and really kind of go deep on how was that process and how was it talking to patients, and how did, obviously you'll work on clinician education and framing and scripting and all of those things. And obviously, depending on how deeply you start with integration and EMR, like right sizing that for every step of the way, and then having some gated decision making. Have we learned enough that we can expand to the next round of clinicians? Have we heard from patients about what they're liking about the solution? And then you kind of get into the walk stage. And that might be where you do deeper EMR integration. You might have a different metric set now that's being shared back and forth, because where you start isn't exactly where you finish. And then the run phase is that deeper integration, data transfer. So you're looking at things in context together, and you're continually optimizing. So it is very dynamic.
I want to go back, Sue. You mentioned something. I think what you're saying is really important, Trina. But Sue, you mentioned like the importance of vertical integration, within the healthcare system. And I wonder if you or all of you have had experience with this. Can you say more about that vertical integration? What needs to happen, and what are the kinds of things that can potentially go wrong, or the challenges that can occur in that integration? Because that can be challenging.
I think to use Trina's analogy, like the crawl phase sometimes can feel the more accessible, especially if you're kind of sizing it up to be a smaller group of clinicians or provider, and your metrics are more doable. Then what can sometimes happen is that you get, again, clinicians or the site leader of one potential healthcare site excited. They have the innovation mindset. They've been open to innovation. They really are trying to address a problem. and it goes wonderfully. From there to the next stage, like how do we continue to then move it to more providers, to other providers, even within, outside of the like 10, like subset of providers within the same clinic or other clinics. Then you need to start talking about with other site clinic leaders or the healthcare leadership as a whole. And that can sometimes be at odds. Just because an innovation is wonderful and it's great and it could address all the problems, it doesn't necessarily mean that sometimes that is aligning with a larger strategy of the healthcare organization as a whole, or the timing might just not be the right time because there might be competing products, or there might be some other slotted innovations that are already in the pipeline that have been kind of surveyed out for the rest of the year. And that kind of then starts to delay your product being integrated larger or scaling up, which then starts to take away, from the partnership and just more maintenance has to be done in order to keep up the excitement. So I think having more of those like transparent conversations up front. Okay, great. So like, are you the deciding maker person to help have these like larger conversations from the beginning? Doesn't mean that you have to have all of those from the start point, but at least going in, okay, not really. So we're going to end at this pilot, and then having some sort of sketched out plan. Like, okay, what would be needed for the next set of conversations? Do we need to go to you? Do you need to come here? Like, who do we talk to? How do we get to that next door so that everyone can have more visibility and feel like it's really a partnership, that we're working together to build the evidence in-house together with this pilot or crawling stage and move together to the next one, rather than feeling like it's just one person or one lopsided partnership where the ownership is falling on one side.
I would say, if I may, the clinical piece is super important. If you haven't sort of gotten the clinical traction, it's going to be really hard to do anything else.
Yes.
But don't underestimate how long sort of a journey with IT or a technical risk office can take. They're going to look at the sort of the EMR integration and the data exchange and privacy, security, HIPAA compliance, table stakes, SOC 2 type 2. They're going to be looking at that and the data exchange, especially with the heightened atmosphere we're seeing with ransomware attacks. That's becoming an even bigger and bigger focus in digital health writ large, over and above digital mental health. So I would say starting those conversations, even as early in the crawl journey, like what are the things you will be expecting to see when we get to walk and we do deeper data integration, like what are the systems in play? You need to be very adept at translating, okay, if we're going to exchange data, what methodologies are we using to ensure there are protocols in place that are private and secure and that are at a standard that the healthcare system, which is a highly regulated industry, can meet. So you as a company are meeting those, and that's table stakes. And then, I would say, as you evolve over time, anybody who's ever worked in an Epic environment, EMR environment, like you're getting in a queue for building things, and you're going to be in a long queue because you're in the queue with everybody else. So don't underestimate how long that can take, because the group you're working with may have a particular time frame in mind, but you have to again leverage that leadership in informatics and ensure that it's important to them as well, and they have you on the path, so you have a sense of your timeline, because that can kind of blow something up as well. So it all matters, and it's important that nobody in that vertical feels blindsided, or they're coming at the last minute and they're being told, go do this. Nobody likes that in any part of their life, right? Regardless of whether it's a work or personal life. So having enough notice and baking in their thinking, and then you can have this gated review, as Sue said. Okay, now we're ready. We've shown these metrics. Now we're ready to go to the next level. But those conversations are almost an iterative rolling. Just when you've that first referral in, you're not done. You're just taking that first step of a very long journey, hopefully a long, illustrious journey, but you have to keep it all in mind. That's the challenge of it.
Yeah, I remember go ahead, Faye.
I was just going to add, for the implementation planning process, I think communication is really key. So how are you communicating with the providers, the payers, or who you're actually piloting with, and engaging them? And then what is the trigger point for the patient to engage? So when I was working with Trina at Kaiser and the Innovation Lab, we found certain interesting triggers. So, if we tried different ones. One is a trigger at the medical office, physician is just administering a kind of an assessment and giving a diagnosis. That's a very compelling trigger for someone to start. Versus I'm getting a mailer out to me, here's something, for your well-being and, and mental health, right? So it's kind of interesting as you kind of think about how you're going to engage. And one thing I find that a lot of startups leave out is the budget and the time and the money they're going to support the training of the the front line to actually implement it. So the training, communication, the engagement, identifying the super users, those change agents from that standpoint. We are creating amazingly intuitive apps, but they tend to be intuitive to us, not necessarily to everyone else. So being sure, in the implementation planning, you're kind of holistic in your plan.
Absolutely.
I want to highlight that distinction because I think there's different strategies that can be helpful, whether you're partnering with a clinician or provider as your vehicle for reaching the patients, or if you are going to be end user or patient directed. And I think the who you train and how, what are the materials and the timeline, and how do you communicate to reach the different groups that you're wanting to reach in order to have the access. At the end of the day, you're accessing the patients, but through which mechanism? There's pros and cons, of course, but they're surprisingly different. I think we partner with some vendors that have a very strong end user directed strategy, and they are when they will talk to us because the way that we work with is by partnering with providers as a referring source. The phases of conversation related to how do we adapt all of the strategies to really make these products be able to sit in this new pathway is also additive to that 12 to 18 months conversation that we just highlighted. So I think if there's possibility to being open to both, great. I think just understanding that they are different and that being flexible enough has its pros and cons on both ends. So that there's also potentially a matching process or a choice at some point available for the vendors and the healthcare systems in order to find the partnership that is going to be optimal in starting as quickly as possible and reaching the data points by reaching providers or patients directly as quickly as possible too.
Yeah, I think you all highlighted how important it is for all members of the team within the healthcare system as well as the company to have a shared understanding of what's happening and to also, I think the theme that you're referring to that came up in the work group over and over again is just the importance of trust and how fragile that can be at times and how important that information is in developing and maintaining trust. You've been talking about the care pathways and where this fits. So I'll use that to kind of move to the next topic. So what have we learned about where in the referral pathways, where in sort of the pathways of these can fit best and what works best in helping patients get connected to digital mental health services and to stay engaged.
Sue, do you want to start with that, with the perhaps digital navigator role, and then I'd be happy to comment. We have a pattern here. We didn't talk about this ahead of time, but I think it's working well. Maybe I'm biased, but go ahead.
So I'm hesitating on the word best. I think I'm going to highlight one pathway that we have found a lot of success with. I don't think it's the only pathway. But within the healthcare system that we've been partnering with, it's worked out pretty well. To highlight the word I used, David, we've really anchored on this word of trust, and trust in the context of relationship trust. So because our entryway is through providers, I as a patient, I'm going to go see my provider's routine care for whatever reason, either my yearly checkup, because I'm not feeling super well, something's off, I'm not quite sure what's going on. I'm going to go to my trusted provider to have this conversation, to start this, to try to identify what's going on with me and what my healthcare needs are. And then from there, then is really equipping then the provider to be the person that is going to be starting this conversation with the patient or on the patient behalf. Like, it sounds like, you know, you might be going through something that may have some sort of behavioral health component to it. Are you open? If patient consents, then great. Then giving and equipping the provider in a very easy, they don't have to go anywhere else. They don't have to learn a new system. It's literally right there where they usually go to. They're not learning something new within their EHR system. They can access all the relevant information, ideally, to aid their decision-making process, just like it was highlighted at the keynote, not to replace the provider, but to really aid their clinical work, and to really facilitate this conversation that is occurring within the trusted relationship itself. That we have found to be really powerful, even if it's truly a 1 to 3 minute conversation. It doesn't have to be longer. It doesn't have to be a 40-minute conversation. That usually is enough to get patients like open and willing to try it out. From there, once they go home, different story, right? Many things can happen in that 20-minute drive from the office to your house. So I think what we have also added to this patient's journey is having another human person that can continue and to leverage that relationship outside of the office and bring it, quote unquote, to the patient's home. So a digital care navigator is available as part of our team, who will be working with the patient, reaching out to the patient directly to really sort of continue that conversation that started at the office visit and really get the patients engaged and get started, address any technical challenges, any hesitations that they had about trying something which is pretty new still. For as much as we live in the digital world, accessing our healthcare in a digital manner is still pretty new, especially in behavioral health. So really making that bridge happen so that the patient is at least open and comfortable and open enough to try it out and then see how that goes. And that connectivity seems to be something that we can kind of expand the trust network a little bit and really truly help the patients try something different.
I would say it's probably not just an issue of technology. Most people do not follow up on referrals for mental health, either to therapists or to specialty mental health. So it's a general problem, but yeah.
Yeah, I would just double click and say the role of that digital navigator is emerging as a workforce of the future type of role, I think, to really complement clinical care and can really boost the referral and uptake and activation into the system. So I'm sort of tracking that. And if you haven't looked at Sue's publications, I would encourage you to do that. I think, what we've learned is the specificity of how can I use this tool, the personalization of how can I use it? Why is it important for me, for the clinician to kind of frame it that way? And then if you can get someone to download it in the visit, in the clinic, that is your best practice right there. Or if you can get the link texted, if you don't have a digital navigator, it can help you walk through that immediacy, the shortened time frame between when you have the discussion and when you can get that referral is a difference maker. Like, Faye talked about triggers earlier for screening, and systems are screening a lot because of HEDIS measures and otherwise, but sometimes, it's coming up in the conversation about somebody not sleeping well. So they're the things that really tend to matter, because you're absolutely right, Sue. Somebody goes home, they go back in their life. I think then having the ability to nudge and say, hey, if you've got a MyChart, app, and there's an ability to nudge somebody, hey, your clinician referred you to this tool and it's still here waiting for you, like having those nudges built in where you're nudging, not nagging necessarily, are also important. And these are like things that we're learning as we deploy. They're just things I'd pull through from there. Faye, what else would you add?
Yeah, no, I mean, that is definitely best practice. But if you're not able to be at the provider's office and have them download or kind of supplement, we've seen some where it's like targeted outreach, right? There have been triggers or tests or diagnosis or assessments or a life-changing kind of event. Targeted outreach. We've also seen that targeted outreach with a kind of, in a sense, webinars, which is kind of a low threshold, so they understand. But then there's also someone there to help them kind of get on the app, understand it, where they're going. So they're interested from that. And so you're, rather than doing a mass mailing, you're already kind of pulling people that want and are ready for change from that.
So this is great. So you got a good plan. You go out and do all the training, get everybody involved, and then you launch it, and it all goes perfectly from there, right?
Of course.
what-
Done.
so what? So best laid plans usually don't go well. So talk about kind of the process of implementation and the kinds of things that go wrong and how those get managed, detected, managed.
I want to highlight the word that Trina used earlier, dynamic. I think the idea that a plan is static, I think will be the hardest thing that will be, because it gives the illusion that, okay, I follow these steps and then I'm good. And then it will naturally follow up after that. And I think that's the hardest thing because it never works out that way. So having a dynamic, less plan and more understanding of what are the key metrics that you're looking for. What are the things that are important for your program, for your content, for your audience? Then really kind of builds in the dynamicism around how do I even collect that? How do I get to those metrics? If my plan A, B, and C usually don't work out, because they usually won't, then I have D and F and how I can adjust easier than if I had a more static, this is the way for us to follow through. So having something that can serve as your anchor throughout this process, because usually it takes a little bit of time to get going. So that allows you also to use the lessons learned from the feedback that you're receiving early on from your early adopters, like this is working really well, great. How do I continue to make that happen more and more? And if your early users are telling you this is something's off here, it's not working, or I need extra resources here, or I need more talking points to really communicate with my patients, whatever that may be, then you can, it's easier to make a decision as a partnership around where to invest more resources, more time to pivot as part of your plan without reaching that end phase of the pilot itself. So I think that having a strong thing will also then allow you to ideally, again, going back to our first part of the conversation today, aligning that framework also with what are the key metrics that are needed for the next stage will be ideal, because then all of the things will kind of be aligned, and the data gathering that you're spending time to really invest time, energy, and resources to collect will be doubly helpful for the phase itself, and then also for later phases. So yeah, there's no like, this is the framework, or these are the metrics, or these are the things that everyone should be doing. But I think having a strong understanding for yourself and your partnership for your program, like why are you choosing the top 3 things that you're willing and wanting to invest time to collect data-wise?
Yeah, I did want to add, because we've talked a lot about clinical effectiveness and adoption and ease of use. I really also think we need to make sure that there's a value proposition, the business case for change. So are you saving the clinician more time so they can see more patients? Are the patients' outcomes, are they healthier and have more mental wellness? Are you reducing ER visits, inpatient days? Are you, so really getting, and like, what is the actual value? Being able to quantify that, I think, is very important. What we've seen post-COVID is, before COVID, it was about 500 million getting invested in mental health startups, which is actually not, it sounds like a lot, but not much. And then it actually mushroomed up to $4 billion during COVID, but it's actually gone down post-COVID to about 2 billion. And so what we've seen is kind of this, there was a big surge because of a huge need, people really, but now it's the market's kind of correcting itself, wanting clinical evidence, traction, engagement, all the things that we're saying here. So kind of in a sense, for the startups and new companies out there, the threshold's a little higher from that standpoint. So what is that business case and value for the change in your company?
Absolutely.
And I think, like, just to piggyback on what Faye said, that some of these metrics will take longer to get access to the data. So like, especially the health economic related metrics are you need a larger N, you need a larger, longer time frame. So I think being able to kind of also understand which one am I going to get now as part of this pilot phase or crawling or walking phase, and then how am I setting up myself to get the other metrics, and within what time frame. Those, I think, are all still very valid and reasonable and expected. I think it's just the understanding and having that foundation, that kind of roadmap available within each company's internal strategy, and having that be part of the conversation from the get-go is what then will usually set up for more success long term.
Well, I've got, I could keep asking you questions, but I'm going to shift to the Q&A here. And if, please feel free, we already have a number of questions, but please feel free to put questions into the Q&A tab there. And along these lines, the first question is around, I think, metrics. He's saying, what are the characteristics of a good goal, but I think kind of what are common or good metrics, and then what about pilots with poor results? So we didn't get to that. So this person's raising it. So
yeah. I think it's a really good question. So thank you for whoever asked it. But I think the poor results is probably easier to answer. So you've built the system, you've trained the teams if you're doing it in a clinically mediated pathway, and you're either seeing a lot of referrals but not a lot of activation. So you've got to really investigate what might be on the continuum of where is that breaking down in the journey. So is it contextually what happened in the visit? Like, did my doctor kind of say this is optional, it might help, or did they really speak to how the app might help you deal more with things you're struggling with? And then also you might have clinicians who are really referring a lot, but the activation is low, or you have clinicians who only refer some, but their activation is high. So really digging into its data and stories, like Sue mentioned this, it's qual and quant. So you really want to look at that to understand where is, if you're not seeing activations or you're not seeing a lot of referrals, like to that's why that maybe first 10 clinicians and first 25 patients is a really important analysis point, because you can really then open up to where things can improve. And then if you bake in improvements to the next cycle, the clinicians feel that and feel heard, and then you're able to kind of get those metrics back. But if you're not clear on why you're deploying, where you're deploying, the pain points you're solving for, or they're very diffuse, you're trying to put your arms around the world, that will be a poor referral. That'll be just a poor deployment writ large, and you may not get to the next phases because you've tried to do too much. So calibrating where you are to where those next few steps is so important. Again, that's why I think the crawl, walk, run enables you to put a methodology on it. Co-panelists, what else would you say?
All right, the next question, I'm really glad that somebody asked more of a business question here. So how would you think about the startup health system relationship in the context of M&A? He says, I'm in Geisinger territory. How would you describe the dynamic of these contracts and relationships in the context of acquisitions?
So the really great question.
Go Faye.
We anticipate more merger and acquisition increasing. Part of it is a market and a need, but what we've also seen is kind of we've done a few national surveys and kind of have our luminary groups too from that, is that when you're a health plan and provider, you don't want to manage like so many solutions that are so point solutions. They want more integrated. So what we see is some of the larger companies are now acquiring some of the point solutions to be able to have that. So if you're a target to be acquired, you really need to think about how you're setting up your business for it to be a clean acquisition, right? Your intellectual property, your team, your cap table, so it's a partnership, right? Usually when you're getting acquired, there is what we call the golden handcuffs period, where you are part of that team, ensuring a successful transition and acquisition. And it's very important for you to have clear expectations on both sides of what that relationship entails. What if it does not go well? What are the exit clauses? What are your parachutes from that standpoint? So we can definitely go a lot more on that. I see Sue nodding her head too. It is a very complex. We do see from the market, as I was mentioning, the market's quite dynamic. It's now kind of moved from a very startup friendly market where we're investing a lot, thousands of mental health companies, to one that is an investor friendly market. So you expect deeper due diligence, a lot more questions from that. The bar is higher of traction, clinical evidence, the points we're making, but then they'll ask your exit plan, and we most commonly see it as merger and acquisition.
All right. The next question here says, engaging clinicians has been mentioned several times. How do you successfully engage clinicians? Many clinicians have very limited time and are often burned out, and adding an additional intervention to their workflow can be challenging, even if there is a value proposition for the patient. How do you make this useful to clinicians? I guess.
Whoever asked that question clearly, something resonates very strongly. Yes, yes, and yes. There's no like magic answer. If you do these 3 steps, I think it will work out. The acknowledgement that even if it's like 1, 2, 3 minute conversation, it is still an addition. It's just one more thing that the provider has to do as part of their, visit. Can be something that is some programs that we've worked with have taken that on even in the designing phase. Like, how do we really optimize in our program content design decisions in order to really maximize, above all other things, provider ease? So that's one. The other one is partnering again with the healthcare system, with super users, with champions, site leadership, to really think about what are the optimal points. And optimal here is, defined as like the one that will lead to the least amount of work, because all of it will be some kind of change on work on the provider side, but the optimal ones that will be helpful and easier, quote unquote, for adoption. And the other one I think we found really successful is kind of going away from this idea that you're one more thing that is being added, but strongly aligning with like, why on earth are you being brought in? Like, what is the really specific patient need or provider need that you're here to address? Showing how your product is really truly geared to address that. And sometimes that means either provider asks you, what about this other stuff? Being able to answer, we don't do that because we're here to answer this, and really being able to distinguish yourself rather than being this like blanket. We can cover everything because everything usually then expands work. And if it's possible, having either early users or someone within the system that can be an advocate for your program, I think is something that is super helpful, whether it's an early adopter, or if you're able to have access to a true champion, like that's someone that can actually implement change within the system, great, that's ideal. But if you don't have access to that, even early adopters and users can also be someone that you can and can be leveraged and should be leveraged, because their voice as a peer will speak thousands stronger volume than if it's someone external, quote unquote, to come in and just and try to convince someone or a group of providers as to why your solution is actually going to be more helpful than, be additive to their workload.
Yeah, I would say all of that. And in my experience, as part of your pilot planning and partnering with the health system, really having, again, identification of innovation-minded clinicians, and then, a percentage of some of their admin time to do this work. Because if you're expecting them to do it on top of their clinical workload or anything else they're doing, it's going to be really, really tough sell. But I think everything Sue said is correct. And, it kind of, they are going to be the voice of their peers and bring along, and you want the warts and all, like you're not going to writing sort of a fairy tale. You want to get at where the problems are going to be so you can begin to solve those honestly. And again, that trust and transparency of, look, this really worked out well, this didn't, any thoughts on how we can make it better. That's how you're building that partnership and trust along the way. But again, in my past life, asking for some admin time, being very clear of expectations, as Faye said, a couple of hours a month or even an hour a month, you take it. It's the 7 a.m. huddles, or there's no such thing as lunchtime at primary care. It's a nice concept, but really sort of understanding where the space is in the day, joining huddles, joining existing departmental meetings, so you adapt as a company to the schedule of your partners, and really kind of showing up with humility and listening.
Yeah, and I would just add to all those too, if you're really just starting out and trying to engage clinicians, I think this society is also has a wonderful group of clinicians engaged that are on early adopters, right? So you'll see them from groups like this. The APA also has an innovation kind of hub and corner too, where they can showcase solutions for providers that are really interested in looking. So I think you can find some, the early adopters are out there and looking and really wanting to find solutions to help their patients.
Absolutely.
All right, well, there are a number of other questions, and I apologize if you put questions in and we didn't have time to get to them, but we are at the top of the hour, so we'll have now a 10-minute break and then follow up with the poster session. So you can have, I think, 6 or 7 different sessions that you can choose from. So thank you, Sue. Thank you, Trina. Thank you, Faye, for
Thank you, everybody.
Thank
a
you.
wonderful for taking the time out for this panel.
Thank you
Thank
all.
you,
Great
David.
questions.
Trina.
Thank you.
Take care.
Take care.
Thanks, David.
Thanks.
Bye-bye.
Bye-bye.
Bye-bye. Bye-bye.